Good evening to everybody entering the room. We're going to start in about a minute or so. Just let everyone get in. Thanks for joining us tonight. Appreciate it. Okay, the participants are trickling in, but we have a long program tonight, so I figure we should get started. My name is Eric Ball. I'm a primary care pediatrician at the CHOC Primary Care Network down here in Orange County, California. I am one of the co-chairs of the California Immunization Coalition Emerging Issues Committee, along with our speaker today, Pia Pannaraj. And welcome to our 7th COVID conversation. Just a few housekeeping notes. Every line will be muted. If you have questions, please put it in the Q&A box in the bottom. We will get to questions at the end of the conversation. We will post this conversation on YouTube and our website a few days later after this is over. Sorry. And then if you have additional questions, you can. Sorry, Cameron, for having you jump around on the call. Anyway, COVID Conversations is sponsored by a joint venture between the California Immunization Coalition, and we're a nonprofit public-private partnership dedicated to achieving full immunization protection for all Californians. We've obviously been very busy this year, as well as the American Academy of Pediatrics in California, which is a partnership of the 3 local California AAP chapters. I am Dr. Eric Ball. Again, I am the co-chair of the Emerging Issues Committee. And our speaker today is my partner in crime in the Emerging Issues Committee, Dr. Pia Pannaraj. So I'm not going to read everything on the screen, but she's an associate professor at the Keck School of Medicine, USC, and infectious disease specialist at Children's Hospital of Los Angeles, and director of the Pediatric Immunization Advancement Laboratory, or PIA Lab, and CHLA's Pediatric Global Health Education Program. More importantly for us, she's on the board of directors of the California Immunization Coalition, and she is the newly elected incoming vice president of our coalition, and she's the co-chair of the Emerging Issues Committee. Today, Dr. Pannaraj is going to talk to us about all the updates that we have on COVID over the past few months. The last time we had one of these was in June, and everything was amazing, and we were going back to dinner and taking our masks off, and things have changed pretty dramatically. So Pia is going to talk to us today about Delta and boosters and third doses and kids and everything else that you guys have been wondering about. And with that, I will hand this over to Dr. Pannaraj. Thank you so much.
Great. Thank you very much for the very nice introduction. Can everybody see my screen okay?
Yes, we can see you perfectly.
Perfect. Okay, great. Yes, so today I will go through a variety of updates. And I do have a couple of disclosures. I do receive some funding either for studies or consultant fees from these different companies. None of them are related to COVID or COVID vaccines. So today, our program includes an update on the current COVID-19 status, including the Delta variant. We will review current vaccine recommendations, examine adverse effects, discuss guidance in younger children and special populations, including the immunocompromised. And I'll tell you about the latest data on long-term immunity and the anticipation of booster doses. All right, so here we are today. Global cases over 209 million, and you could see the graph there. On top, you can see the figure around the world, where we are going on its 3rd large wave. And then in the United States there, you can see where we are over the past month with a sharp increase. And so this was just 1 month ago. You can see that this represents transmission throughout the United States. A lot of that was concentrated in the Texas, sort of middle of the United States and Florida, but in just 1 month, we've pretty much turned red across the entire United States with transmission throughout almost every state. So a lot of this is because of variants, and these variants will continue to come. Variants come about because they're able to spread more quickly in people. They can cause either more mild or more severe disease. It's possible that they can evade detection by viral diagnostic tests and could have decreased susceptibilities to our therapeutic agents, including monoclonal antibodies. And then the one that we also fear is that it can evade existing natural or vaccine-induced immunity. And so these are the main variants of concern that we have seen in the United States. And the WHO labels them alpha, beta, gamma, delta. Delta is the big one that we're seeing now. You could see where they came from, or at least where they were first detected, and then the date of first detection in the United States. Right here. And transmissibility, remember the variants come about because they're able to be transmitted from person to person more easily. So alpha had 29% increased transmission, beta 25%, gamma 38%, but delta 55 to 97%, depending on which study you're looking at. And delta has the ability to transmit. Both vaccinated and unvaccinated people have the ability to transmit delta. So that's very important. Now for severity, alpha had slightly increased hospitalizations, beta had slightly increased mortality, gamma also increased hospitalization. Delta right now it looks like there's increased hospitalization risk. Risk of reinfection for delta, basically shows some decreased neutralization capacity of pre-existing antibody. Luckily, our diagnostic tests still work very well to be able to detect delta. Treatment with monoclonal antibodies, however, there has been some resistance with a monoclonal called BAM-EATS. But other monoclonal antibodies do work against delta, including the one that's being produced by Regeneron. So here is what's happening around the world, and you could see these variants have spread. Alpha's been around the longest, so that's pretty much almost everywhere around the world. Beta, gamma are getting there. Delta is the one that we just detected, but it's also making its way around the world. And again, this map just a couple of weeks ago, it had a lot more white in it. So in the United States, over the last several weeks, Delta has pretty much taken over and is now accounts for 98%, almost 99% of all of the variants that we're seeing across the United States. And so here, this graph shows the number of patients with COVID-19 by age group, and you could see that overall it's increasing, but what is very concerning is on the right side there in children 0 to 17 years old, we see a sharp increase in the number of new hospital admissions in people with COVID. So this is a group where many of us are take care of kids here, and this is the group where we only have vaccines currently available for 12 and over, and none yet for under 12, so that is coming. So here is the vaccination data as of today. So in the United States alone, over 357 million doses have been administered. Now worldwide, it's over 4 billion doses that have been administered. 198 million in the US have received at least one dose, and 168 million have been fully vaccinated. Vaccination coverage, though, does vary significantly by age, state, and race ethnicity. By age, for example, those 65 and older, about 80% of them are vaccinated. However, for the 12 to 18-year-old, it's only about 30%. So there is some room for improvement there. So you can see there's some clusters of unvaccinated persons within the United States. In those clusters shown with the red circles, the vaccination frequency is only about 27%. And if you remember the earlier chart that figure that I showed you, where we had a lot of the initial transmission of COVID, of the Delta strain, it was mostly in those states that are marked in red, showing the low numbers of vaccinated individuals. On the right, you see the figure that with the x-axis showing the percent vaccinated and the y-axis showing number of deaths per million. And you could see that the lower the vaccination rate in the states, the higher number of deaths of the residents in those states, compared with on the high and highly vaccinated states, such as Connecticut and Vermont, have much lower deaths from COVID. So just a kind of reminder of how the vaccines work. So first, the mRNA vaccine. So the vaccine goes in, the mRNA travels to the cell where it provides instructions on how to make the spike protein. And then when you have spike protein throughout your body, the body then makes antibody. The mRNA actually goes away and the spike protein actually goes away, and it's only the antibody that's left that spreads throughout the body to protect you. The Adenovirus Dna Vaccine, which is the Johnson & Johnson vaccine, works in a similar manner, but this time it's an adenovirus that helps to bring DNA into the body, takes it to the cell where the DNA then goes on to make the RNA, and the rest is the same. The RNA makes the spike protein, or teaches the body how to make the spike protein, the antibodies come, and then everything pretty much goes away until you have just the antibody that spreads throughout the body to protect you. So here's a picture of what the spike protein looks like on your left. That's on the virus itself. And normally that spike protein attaches to the human ACE receptor on the human cell. So then when you have antibodies that come in, then it surrounds the spike protein, and you no longer can attach, that virus can no longer attach to the human cell. And so then you're protected. So when you compare the different COVID vaccines that are available, the three that are available in the United States are the Pfizer, BioNTech, and Moderna. Those are both mRNA vaccines. And then the Johnson & Johnson vaccine, which is the viral vector to DNA vaccine. Differences include the number of doses. I think you already know that the mRNA it currently recommends 2 doses, where Johnson & Johnson is a single dose vaccine. The only one available for 12 to 18-year-olds at this time is the Pfizer vaccine. And the efficacy is shown there for severe disease, but most importantly, against hospitalization and death. In those initial studies, it's 100% across the board, across all of the vaccines. So, and then that was the data from the original clinical trials. But in the real world, how is it different? So this was a study that was just published late last month in New England Journal, where they followed a prospective cohort of healthcare workers and essential workers who were vaccinated early in December, January. And following them over time, you could see the efficacy here, for those that were partially vaccinated, it was 81%, and for those who were fully vaccinated, 91%. So even in the real world, effectiveness was actually quite high. More importantly, when you look at those who received vaccine, even if they were infected, they still had, compared to those that did not have vaccine, those who were vaccinated had decreased viral load, decreased duration of detection, decreased febrile symptoms, decreased total days of symptoms, and decreased days spent sick in bed. So I think overall, basically, this still shows that even if you get infected after being vaccinated, overall, everything having to do with the infection is improved. So now with all of our variants, there's this concern, or do the vaccines still work? Are they still effective? And so this figure here shows with all of the different variants, so protection against severe disease, that line there shows that particularly for Delta, that AstraZeneca and Pfizer still seem to be working well against severe disease. For symptomatic disease and infection, however, there's slightly decreased effectiveness. But again, the most important thing to prevent is severe disease. So, and then here again, real world data as opposed to trial data, 2 doses of Pfizer has 88% protection, whereas 1 dose only has 30% protection. So in many of the European countries, they were initially trying to vaccinate everybody with 1 dose across the board before going to the 2nd dose, hoping to protect more people. But unfortunately, against the Delta variant, this strategy did not work so well. So the protection for 1 dose was only 30%, or 2 doses was really much higher at 88%. So what about vaccines in children? I get asked a lot, why do we need to vaccinate children? Children seem like they don't get too sick when they get COVID. Many of them are asymptomatic. However, there were over 4 million children diagnosed with COVID basically since COVID began. And they account for 14.4% of all cases. And in the last week, actually accounted for nearly 20% of all cases of new diagnosed COVID. There have been over 400 deaths and over 4,000 MIS-C cases, the multi-inflammatory syndrome that comes after the initial infection. And that has led to 37 deaths. And then they may be important drivers of community spread, especially when the restrictions are lifted. And of course, there is this current concern with children being back in school. But the goal really is to get them back in school, to get them to return to having a normal life and to be able to see their friends and their teachers and be children while still being protected against COVID. So in our own study here in Los Angeles, where we conducted a household transmission study, that this study included many large multi-generational families. And we actually found that children, shown here in green, represented a large percentage of the index case, especially when COVID numbers were relatively low in the community. When the COVID numbers were high, then it was the adults that usually were the index case that brought the COVID home. And so there's actually another study that just was released in the last day or two from Canada that also shows that children represent more of the index cases than we originally thought. And this may be, and this study done here in LA was actually even before schools reopened. And we wonder if during that time, the children were still more together in some of these lower income families where they would play together during the day when there's no school. and nobody to watch them. So, so that's a concern. And then when children go home, they actually do spread COVID to the rest of the family, mostly to mom, who may be the primary caretaker, but also to dad and other adults, as well as to other children. So that is also a concern now, and especially with the Delta variant, which is even more transmissible. So the vaccine that's currently approved down to 12 years of age is the Pfizer vaccine. And this was the original data that led to its approval. This was a phase 3 clinical trial conducted between October of last year and March of this year. And they found that side effects were very similar to the 16 to 25-year-old age group. Neutralizing antibody titers were the same. And you can see here that they had roughly 1,000 participants who received the vaccine versus 1,000 placebo, and there were 0 cases in the vaccine group compared to 18 in the placebo group. So that efficacy was 100%. The Moderna trial, which is currently, this data is currently under review by the FDA, and with the hopes of obtaining emergency use authorization. This data was a phase 2 to 3 trial in 12 to 17-year-olds. And they also saw similar side effects compared to the young adult age group, and similar neutralizing antibody. In this study, they randomized 2 to 1, so more people got the vaccine than placebo. When you look at symptomatic cases, there was 1 in the vaccine group and 7 in the placebo, leading to 93% efficacy. That's a pretty good number. But when you looked at any COVID infection, there were 27 in the vaccine group and 42 in the placebo, giving an efficacy of 69%. But just like I mentioned earlier, it's really the symptomatic disease that we are aiming to prevent. And so this data has been under review by the FDA since about mid-June. So we're hoping for some decision soon. So I talked a little bit about the side effects, and just to show you here, this is from the Pfizer study, but the Moderna study is very similar. It's mostly pain at the injection site, just like what we see in adults, and pretty much everybody that's getting the vaccine. Systemic effects include fatigue, headache, muscle pain, and it's the same thing after first and second dose, perhaps a little bit higher after the second dose. Then the VAERS early nation reporting is the nation's early reporting warning system, and so that they've also detected some dizziness and syncope. And so in this age group, remember they're adolescents, very similar to other adolescent vaccines. It's important to watch for any signs of dizziness or syncope, and to have them stay in the office for at least 15 minutes for monitoring before sending them off. So, but there are many concerns, and these are the questions that I receive the most. Concerns about myocarditis, thrombosis, and Guillain Barre. So I'm going to go through each of these in a little bit more detail, especially myocarditis. So myocarditis and pericarditis was detected through the VAERS system. So it goes to show you that that system does really work. So most of these cases were detected after about 300 million mRNA doses were administered. And there were, the numbers here show you the reports after first dose, 267, 827 after the second dose, and then 132 reports after unknown dose. In the figure here, blue represents dose 1 and red represents dose 2, and you can see that most of these occurred within the first week of the vaccination. So and the characteristics of these individuals, the median age was 24 to 30. But the range you could see is pretty much the range of vaccination. Median time to symptom onset was 4 days after dose 1 and 3 days after dose 2. Most of these were male compared to female. And the symptoms that they presented with were often chest pain, dyspnea, and there were ST or T wave changes found on EKG, elevated cardiac enzymes or abnormal echo. So when the data was reviewed, and compared to what we normally see for myocarditis and pericarditis. So you could see the expected column for both females and males is what we normally see, and then the observed is what we saw with after the vaccine. And so the observed numbers in red are the ones that were more than expected. And so you could see that the age groups that were affected were mainly the adolescent and young adult age groups. And again, primarily more in males compared to females. So this is the rates for overall, if you took all age groups together. So in female, the rate is 4.7 per million doses, and in male, 32 per million doses. Now, when you look at all of those cases that were reported, most of them did require hospitalization. However, the median length of hospital stay was only 1 day, which is much shorter than a normal diagnosis of myocarditis or pericarditis. And most of those were discharged home right after and normal at the time of follow-up. So I think that that's really important to remember that that there is this fear of myocarditis, but for the majority of cases, almost all the cases, the median length of hospital stay again was 1 day, and they did well afterwards. COVID-19 infection itself, natural infection, does cause myocarditis. These are 2 studies that linked SARS-CoV-2 infection with myocarditis. It's thought that for a natural infection that the virus invades the cardiomyocytes and can cause inflammation. But some of these individuals had, even though they had abnormal MRI findings, they actually did not have any symptoms. They were just being checked as part of a study. So the important thing whenever we learn about side effects is to weigh the risks and benefits of the vaccine. So this slide shows the predicted number of cases of myocarditis for every million vaccinations given. So it's divided into females on the left and males on the right, and by age group. So this is adolescents 12 to 17 years old. So for every million doses vaccinated, I'm going to focus on the males because that's where the majority of the myocarditis cases occurred. So for every million doses received, the vaccine prevented 5,700 COVID cases, 215 hospitalizations, and 71 ICU admissions, but potentially caused 56 to 69 myocarditis cases. Remember that the majority of those are mild. For males 18 to 29, for every million doses given, 9,600 COVID cases were prevented, including 300 hospitalizations and 60 ICU admissions, while potentially causing 22 to 27 myocarditis cases. And then for 30 to 49-year-old males, 11,000 cases were prevented, including 700 hospitalizations, while 5 to 6 myocarditis cases may have occurred. So you could see here, when you look at the risk-benefit ratio, the benefit of vaccination and preventing hospitalization, preventing ICU admissions and deaths is much higher than the potential, than the number of myocarditis cases that occur. So this is the current consideration in people who have a history of myocarditis. So if there was myocarditis or pericarditis diagnosis previous to any COVID-19 vaccination, in other words, in their medical history has nothing to do with COVID, then the recommendation is to go ahead and proceed with the COVID-19 vaccine, any of them. If somebody has myocarditis or pericarditis after the first dose of an mRNA vaccine, but before the second dose, the recommendation is to defer giving the second dose until more data is available. But at the same time, you have to consider what the level of community transmission is at the time. So right now, when there is very high community transmission, you may be more likely to proceed with the second dose after resolution of symptoms. Also, you should consider the personal risk of that individual if they have any other underlying disease or on any immunomodulators, then their risk of a complication from COVID is much more severe than the risk of developing myocarditis or pericarditis again. All right, so I wanted to move on to thromboses. So these are rare clotting events that occurred after the COVID-19 adenovirus vector vaccines, and was first reported mainly in Europe following the AstraZeneca vaccine. I didn't talk about this vaccine too much, but it's very similar to the Johnson & Johnson vaccine that we have here. It's an adenovirus vector vaccine. And so this was the timeline for the Johnson & Johnson vaccine here in the United States. It received emergency use authorization back in February. There was a lot of, public health officials and everyone was very excited about the Johnson & Johnson vaccine because it's a one-dose vaccine and doesn't have the stringent freezer requirements that the mRNA vaccines do. So vaccination began in March, and since then, a little bit over 12 million doses have been given, and there have been 38 cases of thromboses with thrombocytopenia, and this is and you can have what's very severe about it is it's cerebral vascular venous sinus thrombosis. Most of these have occurred in women 18 to 64 years old, and onset is about 6 to 13 days after vaccination. And so again, the highest risk is in women. Really the highest risk is 30 to 49 years old. So after, so if you may remember that the ACIP and FDA recommended a pause on the Johnson & Johnson vaccinations as the data was being reviewed, gathered and reviewed. It was a very short pause, but you can see the number of doses administered. So Johnson & Johnson in blue at the bottom was on its way up when the pause happened, and then there was a sharp drop in the number of doses administered, and it's never quite picked back up. The other concern about Johnson & Johnson has been the Guillain Barre syndrome. So normally there are about 3,000 to 6,000 cases per year seen in the United States, with highest risk in males over 50 years old. This is in a normal, non-COVID, non-vaccine related year. And so after the vaccine was given, again, about 12.5 million doses, there have been 100 Guillain Barre cases seen that were thought to be due to or very closely related to the Johnson & Johnson vaccine. Most of these were male, but still about 61%, 38% female. These cases were more serious. Almost all of them were hospitalized. There was one death. And here, median age 57 years old, but there were many between 18 to 64 years of age, 83%. Time to onset was about 13 days after receipt of the vaccine, and most 84% occurred within 21 days of receipt of the vaccine. So, and they went back and looked to see if Guillain Barre occurred after either of the mRNA vaccines, the Moderna or Pfizer vaccines, and you could see here that that the rate per million doses administered was much higher in following the Janssen or Johnson & Johnson vaccine. So the rate is 8 per million doses administered, where with the mRNA vaccines, it's 1 per million doses administered. And that may be well within just a normal baseline rate. So, so when looking at the Johnson & Johnson vaccines, this is what we have to weigh. Again, the risks and benefits. So the benefits here are shown on the left. These are the number of hospitalizations and deaths that are prevented by giving the Johnson & Johnson vaccine, compared to on the right in red and black, the red, the number of Guillain-Barré syndrome cases, and in black, the thrombosis with thrombocytopenia cases. So you can see here again that the benefits far outweigh the risks. In addition, if an individual falls into one of the age groups that is of concern, there is the possibility, or if somebody has history of Guillain-Barré, for example, and there's some concern, we in the United States are lucky enough to be able to have alternative vaccines, that we have the mRNA vaccines, and vice versa. If there's somebody that where there's concern for the mRNA vaccine, we have the Johnson & Johnson vaccine. Not every country around the world has that same fortune to be able to have a choice of vaccines. So some additional benefits of vaccination are to prevent post-COVID conditions. We sometimes don't think about these as much, but they include MIS-C, prolonged symptoms, such as long haul COVID or long COVID. These are people that continue to have symptoms, including shortness of breath, fatigue, months after their initial infection, many times 3 to 6 months. There is some anecdotal data that those symptoms actually do improve after vaccination. And then the vaccines, of course, protect against the variants that we talked about earlier. So I just wanted to put in one slide to talk about vaccine co-administration. And that's just to say that the COVID vaccines may be administered at the same time or within 14 days of any other vaccine. So this was not the recommendation at the beginning, but has been the recommendation for at least the last 2 months. So because, you know, what's important to know right now is that the routine vaccines are low. People hadn't been coming to the offices to receive their vaccines. Adolescent vaccines in particularly have decreased significantly. We are also coming up on for flu vaccine time. So the COVID vaccines can be administered with any of those other vaccines at the same time. Okay. Today I want to talk about vaccinations in younger children and special populations. So the vaccine trials in younger children are ongoing. So here the Pfizer trial, it's phase 2 to 3, ongoing in 5 to 10-year-olds. They are using a slightly lower dose compared to the adult dose. Planned enrollment is 4,500 in multiple countries, and they anticipate initial results in September and anticipate sending that to the FDA for emergency use authorization, hopefully in October, early November. And then after that, they have already started enrolling 2 to 5 year olds in that. So that data is expected shortly after. And then after that will be 6 months to 2 years old. That data expected in December. The Moderna vaccine, first the 12 to 17-year-old data that I presented earlier is under review for emergency use authorization, but their phase 2 to 3 study in 6 month to 11-year-olds began back in March. And they're continuing that with the planned enrollment of 6,700 in the US and Canada. So they'll be evaluating safety, tolerability, reactogenicity, and effectiveness. In the meantime, for their very young babies, the CDC just updated their recommendation or their language for pregnancy and breastfeeding. So there's no evidence that any of the COVID-19 vaccines affect current or future fertility. The vaccines do not cause infection in those that are vaccinated. There have been no safety signals done in animal studies. There's reassuring safety data in those who have received the vaccine while pregnant, and it's been shown that the vaccine has been effective. So now the recommendation says that COVID vaccination is recommended for all people age 12 and older, including people who are pregnant, lactating, trying to get pregnant, or might become pregnant in the future. So I think it's very helpful that they've just updated that wording to help OBs and others make the recommendation in pregnant women. There have been some studies that have looked at antibody in cord blood, and there is definitely antibody there in cord blood, and some in even our own studies that we're doing here on very small numbers, we actually see a higher level of antibody in cord blood than we see in mom's blood. You know, it's a mother's gift that they're shifting a lot of that antibody to the baby through the placenta. So baby will have some transplacental antibody being transferred. In addition, breastfeeding may offer protection against COVID-19. So in those that were vaccinated, we see an increase in IgG and IgA post-vaccination that persists up to about 6 months. Neutralizing activity is definitely there at 1 and 3 months, but does start to drop a little bit at 6 months. Kind of similar data, as I'll show you, to serum studies. So, and in addition, we've looked at, does that IgA, COVID-specific IgA, stick around pre and after pasteurization? So, for example, in those NICU babies that are getting milk from moms that are vaccinated, are they being protected? And a study that was done previously looking at pre and post pasteurization of milk after natural infection showed that the antibody stayed there, and it's the same for pre and post pasteurization following vaccination. So those NICU babies could be protected as well. So what about after MIS-C? So this is another question that I seem to get a lot. If somebody has MIS-C, should they get the vaccine? So the recommendation is that that the vaccine should be considered after 90 days from diagnosis or treatment of MIS-C. So the idea is that those kids that developed MIS-C or adults that developed MIS-A were infected before. And so that antibody should stick around for at least 90 days. Other factors to consider are clinical recovery and return to normal cardiac function, other underlying conditions and immunosuppression, as well as level of community transmission, just like you heard earlier about myocarditis. So Now, this is the one of the newer recommendations just made in the last week, was the recommendation to immunize give a third dose to immunocompromised individuals. In the United States, immunocompromised individuals account for about 2.7% of adults. That's 7 million adults. They have increased risk of severe infection, prolonged infection, and shedding. We have shown in some of our patients who have had prolonged shedding of COVID-19 over 6 months, that during that time, within that same individual, that COVID mutates and turns into different variants, all within the same host, in the immunocompromised host during that time. So that's definitely a high, those are high risk individuals. And vaccination breakthrough, within the vaccination breakthrough infections of those who are hospitalized, 44% of those are immunocompromised in the United States. So this figure here shows basically summary of 63 different studies that looked at immunocompromised hosts. And you could see that looking at percent with antibody response, the lowest response was seen in organ transplant recipients, but the others do have slightly lower responses as well. So, and then this is basically data showing the third vaccine dose, and you could see in green the number of people who converted to seropositivity after the third dose. Among those who had no detectable antibody response, 33 to 50% developed antibody to the additional dose. So it's not perfect, but at least you get about a third to 50% more people who will have some kind of detectable antibody response. So there've been a couple different studies looking at the doses, the third dose, and all of them showed similar data that you increase the number of people who respond after the third dose. And importantly, there's been no serious adverse events reported and no episodes of acute rejection. That's both in Pfizer trials as well as Moderna trials shown here. So internationally, there have been recommendations made for a third dose in France, the UK, Israel, and Germany. Germany just recently in the last couple of weeks. So US has now followed. As of August 12th, the FDA has authorized an additional mRNA vaccine dose for immunocompromised individuals, moderate to severely immunocompromised. Attempts should be made to match that additional dose type to the first primary series type. So in other words, if they got Pfizer, they should ideally get Pfizer again. If they got Moderna, they should get Moderna again. And that dose should ideally come at least 4 weeks after completion of the primary series. Testing for antibody is not recommended because we don't know we don't have a correlate of protection. We don't know what antibody level is protective. And whenever possible, 3 mRNA vaccine doses should be given at least 2 weeks prior to initiation of any immunosuppressive therapy if time permits. This EUA amendment does not apply to the Johnson & Johnson vaccine or Janssen vaccine, but there is more data that's expected to come out with new recommendations for that. This is a list of the moderately to severe immunocompromised, and you can find this list on the CDC website. So finally, in the last few minutes, I want to talk about booster doses. So booster doses is a little bit different for what the recommendation for 3 doses for the immunocompromised. That's considered, those are for people that may never have had a good response, that they should get a third dose. Booster doses are for those who did have a good initial immune response, but perhaps have the immunity has waned over time. And so there's been some studies that have looked at antibody persistence over time. The data, the figures shown here are from our own studies of about 300 vaccinated individuals. And you could see in the blue on the bottom that's natural infection. You have antibody that persists at least to about 9 months. In those who have been vaccinated, if they had in green previous infection, they actually have the highest amount of antibody after vaccination, but it does come down over time, but stays higher than this red pink here, which is those who did not have previous infection but were vaccinated. The good thing is that if you look at neutralizing antibody on this figure on the right, you could see that those who were vaccinated at 6 months, they still have decent neutralizing activity. And those who had natural infection 10 to 12 months still had, for the most part, decent neutralizing activity, but there were some where that neutralizing activity was gone. Data from other places have shown a variance in neutralizing antibody at 6 months, particularly against certain strains. So again, some strains it works and some strains it doesn't. And so that's why there has been all this talk about booster vaccines. So in addition, one other thing that we've looked at are CD4 and CD8 cells and their response to vaccination. So again, you could see it increases at 1 month and 3 months post-vaccination, but it starts to go down by 6 months post-vaccination in blue there, and same for CD8. And so it seems like by 8 to 9 months, that might go away. And so the real world efficacy data kind of shows the same thing, that initial efficacy is 96%, but it goes down 2 to 4 months to 90%, 4 to 6 months to 84%, which is not horrible, but then again, as you continue the number of months from vaccine, that vaccine effectiveness will go down. So there have been, so the White House just this week has talked about booster shots, and today gave a date, said booster shots will be offered beginning September 20th, 2021. This will be 8 months after the initiation of COVID vaccines. Now this does need FDA approval. And so the recommendation will be that anybody who has where it's been at least 8 months is eligible for a booster vaccine. And that recommendation is specifically for mRNA vaccines. However, the Johnson & Johnson vaccine second dose recommendations are also anticipated soon, because they started their 2 dose versus 1 dose trial actually right after the EUA was granted for their vaccine. So that data is expected to undergo FDA review in the next month or so. So I talked about a lot of things today. Here is the summary. Vaccination continues to be critical during this period of rapidly increasing cases and spread of variants of concern. The reported adverse events, including Guillain Barre, myocarditis, and thrombosis, are potentially serious and should be transparently communicated with the public. But overall, the benefits of vaccination outweigh the risks for most possible adverse events. And also, the communication allows people to be able to choose different vaccines that may be less of a risk for that particular individual. Additional pediatric data for the 5 to 11-year-old is expected in September, with hopefully approval by October, November. The third mRNA dose for immunocompromised individuals is now recommended, and booster doses are inevitable, just awaiting more data for FDA approval. So that is my talk. This is our group that this was us the day right after we received all of our vaccines right before Christmas, and so we were all celebrating and very happy. But they're the ones who did all the work, the data that I presented. So everything.
Looks like the Pia lab is ready for their booster doses if it was at Christmas time.
Yes, they are.
Dr.
Great.
Pannaraj, thank you so much for that excellent, thorough update on COVID. I think we have just a few minutes for a few questions. So we had some questions that were submitted beforehand and some during the talk. A question that we had a few times was, if we're giving booster doses to people and the nature of the SARS-CoV virus has changed with a primarily a Delta variant now, why are we, and it's easy for them to kind of change the recipe of mRNA vaccines, why are we giving a third dose of the same vaccine and not like a new vaccine that primarily goes after the Delta variant?
Yeah, that's a great question. A lot of that has to do with safety data that's available. So there has been at least one study published so far that looks at a variant booster. And I actually just kind of slided over this slide, but basically that it does show that there's increased protection against the variants with the variant booster, which is great, but it's only one study. And so we need a lot more studies like this. Fortunately, we do have studies that do show safety of using the same vaccine that we received previously and giving the third dose as the booster. And so that is why that's the current recommendation. I think in the future, we will have variant boosters.
Another question that was asked several times was that initially the CDC recommended that those folks who had a previous COVID infection wait at least 90 days after their COVID infection to get vaccinated. And I think that was largely because there was a lack of adequate vaccine in the country at the time. I believe that has changed, but some people have asked, what's your guidance for someone who, let's say, had COVID 2 weeks ago?
Yeah, so they can wait, but you're right. That initial recommendation was because we had a shortage and we knew that the antibody lasted at least 90 days. Now we know that those who receive vaccine, even if they were infected before, actually have a better immune response. So I showed you a little bit of data that they have better antibody response. They also have better neutralizing ability against more variants if they had both infection and the vaccine. So you can almost see it as the silver lining of getting infected. If you did well and then you get vaccinated, you actually have the best possible protection. So that's why the recommendation is now to just go ahead and get that vaccine after you recover from the acute infection.
I'll end with one final question. Actually, at one of our educational meetings on Monday, Dorit Rice, who's a law professor at UC Hastings, talked about how mandates for vaccines are a little bit easier once it's officially approved by the Food and Drug Administration. Any insight as to where that process is going?
Sorry, I missed that very last part of the question.
I was wondering if you heard any information about when these vaccines will be officially approved versus an emergency use authorization from the FDA.
The FDA approval is expected pretty much any day now. It has been under review for some time. The initial estimates were September, so it may be any day now and through September that we expect that full FDA approval.
Fantastic. Thank you so much, Dr. Pannaraj, for giving this talk today. It was very helpful, a lot of information in there. Thank you all for joining us. There will be an evaluation that will pop up on your screen after this is done. Please complete it. It really helps guide us for future COVID conversations. We are trying to have this every month or two, and we're trying to keep up with hot topics. So please stay tuned. We will post these to our social media channels and on our website. And then again, all of these previous COVID conversations can be found on our YouTube channel or on the California Immunization Coalition website at immunizeca.org. Thank you all so much for joining us, and we look forward to seeing you soon in the near future.